morning, everyone. Welcome to today's installment of Anesthesia Learning. Today, I'm going to talk all about inhalant anesthetics. Inhalant anesthetics are pretty unique because, unlike injectable drugs, they have a couple of very unique properties which make them easy to use, rapidly reversible, and very common in all parts of the world. And today, I'll be talking a little bit about how they work, how they don't work, and some basic properties behind all of those things. I will give you some relevant definitions when it comes to working with inhalant anesthetics that you need to know. I'll talk about how they move inside and outside of the body because that's something you're going to have to understand when you're doing anesthesia on animals every day. And I'll talk a little bit about how to optimize induction quality, induction speed, and a couple of other things related to inhalant anesthetics. So let's start talking about some of the basic things about inhalant anesthetics that make them interesting and some of the things that can make them difficult to work with. Now, I know that there's a lot of writing on the screen, so what we will do is that we'll have a picture of this that will be uploaded to our online learning platform, so do not worry about being able to see all of this necessarily. We will be able to see this at a later time. You can, of course, show up in person where you can see it very easily. So let's start from the top with a couple of the pros about inhalant anesthetics. So one of the nice things about inhalant anesthetics is that they're taken up and eliminated by the lungs. This is great because compared to other drugs which are metabolized by, let's say, the liver, the kidneys, substances in our plasma, these drugs are eliminated by the lungs. So they usually provide rapid, reversible, very easily adjustable plan of anesthesia, which is really nice, right? So if you turn up the vaporizer, the patient's probably going to fall asleep, and if you turn it off, they're going to wake up very quickly. Now, there are some caveats to that, but I will elucidate that later on in the lecture. Some anesthetic drugs, some inhalant anesthetics are metabolized, so a lot of our modern agents are not, but things like halothane, which we are not using commercially anymore, that is partially metabolized by the liver. So depending on what part of the world you end up working with and what you have available, you should be aware of what drugs and what inhalants are going to be metabolized by the body. So those are the nice things about inhalant anesthetics. Now I want to talk about some of the main cons, like the things we see every day that impact us. So one of the biggest problems we have with almost every inhalant anesthetic is that they do something called impairing calcium cycling. So calcium is very important in the body for many reasons. So calcium is required for vascular tone, so arterial and venous blood vessel tone. It is also important for excitation contraction coupling. So basically the heart contracting nice and strong and regularly. So basically what this means is that if you give animals inhalant anesthetics, it decreases cardiac contractility, usually in a dose-dependent fashion. So the higher your vaporizer, the more you make the contractility bad. It also causes things like vaso and venodilation, so dilation of the arterial vessels and dilation of the venous vessels. And this will lead to, usually, arterial hypotension. Now, usually these things happen in a dose-dependent fashion, but if you have a patient that is particularly debilitated, let's say they're dehydrated, maybe they're old, they have decreased sympathetic outflow, maybe your patient's going to be differently affected by this. So, impairing calcium cycling, this decreases contractility and causes vasodilation. And when we decrease contractility, we decrease the systolic blood pressure. When we cause vaso and venodilation, we decrease the diastolic blood pressure. And together, those things will decrease the mean arterial pressure. And we need a good mean arterial pressure to deliver nutrients and oxygen source to different tissues in the body, so it's very important that we try to maintain that. And this is one of the things why it's so important to have a balanced anesthetic technique, okay? Use different drugs and use different amounts of inhalant to accomplish what you want. You get minimal side effects of each drug. So, most inhalant anesthetics do not provide analgesia, and this is something that's very important to remember when you're doing balanced anesthesia, okay? So there are one or two that do provide analgesia. We do not use them a lot commercially anymore. Nitrous oxide and xenon. I've never used xenon. I had access to nitrous a couple years ago, but for fear of toxicity and also it's not very potent, we tend not to use it clinically in practice. So inhalants do not provide analgesia. They just provide muscle relaxation and unconsciousness. So you need to provide other ways to prevent pain and nociception in patients. It is not acceptable just to give them more gas. And there are certain inhalant anesthetics that produce toxic compounds. Sevoflurane would be an example of one of those. So some of our inhalant anesthetics, when interacting with other substances in the anesthetic circuit, they can produce toxic compounds that mainly have to do with nephro or kidney toxicity. So these are all things that you should be aware of when you're thinking about using inhalant anesthetics. So next I want to talk about a couple of basic anesthesia physics and pharmacokinetic things that you should be aware of when you're dealing with inhalants. So when we talk about inhalants, usually we call them gas, sometimes we call what comes out of the vaporizer vapor. So I just kind of want to separate those definitions and make sure that you understand that they each have very distinct roles. So a gas is something that exists in a gaseous form at room temperature and room pressure. So a gas, something that would be an example of that is nitrogen and oxygen that is just hanging around in the air. And there is a pretty big difference between a gas and a vapor, where a gas exists at a gaseous state at room temperature and pressure. A vapor is a gaseous state of a substance that, at those same conditions, at room temperature and ambient pressure, is a liquid in those conditions. So if you have liquid isoflurane or liquid sevoflurane and the molecules start entering the gas immediately above the liquid, that substance that you have there, that is the vapor. That is the inhalant anesthetic vapor. So it was a liquid, but at room temperature and room pressure, it is becoming a vapor. Does that make sense? It's converting from one substance to another. Now I want to talk about how those substances kind of come to be in the body. So the amount of inhalant that we end up giving animals, it's a little bit differently described than injectable drugs. So when we talk about injectable drugs, we're usually talking about milliliters, we're talking about milligrams. So inhalant anesthetics are going to be a little bit different because they exist in a gaseous state and they are vapors. So inhalant quantity is described as something called volume percent, where basically the percent of the agent is X percent of whatever the total gas mixture is. And this makes sense, right? So if you set your vaporizer to 2%, basically what that means is that 2% of the total gas mixture that is leaving that vaporizer, so remember that we put oxygen into it, 2% of that entire mixture is isoflurane vapor, and that makes sense, right? So it is a relative quantity. It is whatever 2% or whatever percent you set of it that is leaving the vaporizer. And obviously that amount is going to change depending on, how big of a space you are filling with that gas, okay? Partial pressure is something different, and it's very important when it comes to inhalant anesthetics and how they work. So partial pressure is the individual pressure of each gas in a mixture, usually in a closed container. And this is really important because partial pressure is an absolute value. Volume percent is not an absolute value. So when we talk about how inhalant anesthetics work in the body, what we want to achieve is an adequate partial pressure in order to cause anesthesia, because anesthesia is going to allow us to do things like achieving muscle relaxation and unconsciousness, and then have reversible and adjustable depth. So it's the partial pressure that we really care about at the end of the day. Now I want to talk about one of the main principles behind how inhalant anesthetic works and how they result in induction and how they result in recovery. And this is something that's very important and will account for differences between things like sevoflurane and isoflurane. So the blood gas partition coefficient, sometimes it's abbreviated as BGPC. So when you see things like that, that is exactly what that is. So the blood gas partition coefficient, this is a number or a ratio, and basically what it tells you is that at equilibrium, how that inhalant anesthetic is going to divide itself or partition itself between the gaseous and the soluble states. So basically what this means is that at equilibrium, what we're going to have is that we're going to have some inhalant anesthetic that's over here in a gaseous form. It's a vapor, but it's in a gaseous form, right? And we're going to have something on the other side that's usually a tissue. So the inhalant anesthetic is going to partition itself, depending on its properties, selectively between those two different states. And this really has to do with how they work in the body. So I've drawn a couple of totally accurate and very detailed diagrams to illustrate the principle of blood gas partition coefficient. Now, what I will say to you is that you don't necessarily need to remember these numbers, but I want you to understand what they mean, okay? So that's the important part. So, blood gas partition coefficient, it tells us at equilibrium how that agent partitions itself. So, let's go over here to agent 1. So let's say I have two compartments. I've got blood and I've got gas. This is a very real scenario because what you want is that inhalant travels from the vaporizer. It's going to go down to your lungs, so there's gas in there. And then right around the lungs is the arterial blood supply, right? So it needs to go from the lungs into the arterial blood supply where it's going to be taken to tissues. So that is why the blood and the gas barrier is kind of important. So blood and gas. So let's say I have agent number 1. So we've reached equilibrium. The inhalant anesthetic has been allowed to transition between these two compartments. And at equilibrium, agent 1 has 1 molecule in the blood and 2 molecules in the gas. So it's the quantity of one to the other. So there's 1 over here and 2 down here. In this imaginary scenario, the blood gas partition coefficient is 0.5. So this is what this means. At equilibrium, the concentration of agent number 1 will be twice as high in gas as opposed to blood. So, and with agent number 2, what we're going to have is that we have 2 of these molecules in the blood, and we have 1 in the gas state. So, what that means is that agent number 1 has selectively partitioned itself primarily in gas, less in blood. It did not dissolve very much in blood. That means that agent number 1 is relatively insoluble. These markers are not very good, but we will have pictures of this for later. And agent number 2 has selectively partitioned itself into the blood as opposed to the gas. So what this means is that if agent number 2 has dumped itself into the blood, its blood gas partition coefficient is 2 and this one is 0.5. Agent number 2 is going to be more soluble in blood. So it's going to go into the blood more easily. Okay, so, and basically what those things mean is that these have to do with the speed of induction and the speed of anesthetic recovery. So, if you have an agent that has a very low blood gas partition coefficient, that means that it selectively partitions itself more in gas as opposed to blood. So the lower the BGPC is, generally speaking, the faster the anesthetic induction and the faster the anesthetic recovery. And usually why this is because let's say you are not very soluble in blood. The anesthetic is going to come to the lungs, it is going to be in the gas, it is going to, some of it will go into the blood, but then it's going to go from the blood into the tissues very quickly because it's insoluble. It's going to go one place and then it's going to go to the other. So, for that reason, anesthetics with low blood gas partition coefficient usually result in fast quality induction and fast quality recovery. So, for example, you do not need to remember these numbers, but they might just be important to kind of keep in mind because you'll remember how they work. Desflurane, this is an inhalant anesthetic we don't commonly use, but it's still on the market. Blood gas partition coefficient is 0.42. And there are studies that have compared anesthetic recovery times in dogs when they put them on desflurane, sevoflurane, and isoflurane. And it makes sense that if the blood gas partition coefficient of desflurane is the lowest, that the recovery was the fastest, and this is indeed true. So sevoflurane is next up, so it will be slightly slower than desflurane, but it's faster than isoflurane, and isoflurane tends to be the slowest. So this is one of the reasons that some people prefer using sevo or desflurane in certain species, just because of their solubility, because they're relatively insoluble. They will result in a faster anesthetic induction and recovery because that inhalant is going to go from the gas in the lung into the blood, into the tissue relatively quickly, and it's also going to tend to leave fairly quickly as well. The only thing this means is that it's faster, okay? Just because something is faster does not necessarily mean it is safer or better for the animal. Overall, the most important thing is the quality of your care, the balance of your technique, the trends in your monitoring. So if I drive at 60 miles an hour to Columbia, Missouri, I will get there, in maybe 2 hours and change. If I drive at 90 miles an hour, I'm going to get there faster. It doesn't mean I did things better. It doesn't mean it is better for the animal that I have in my car that I'm trying to take to Columbia. It just means I got there faster. So just keep that in mind. But if you're thinking about recovery times, that's what you want to think about. So the converse is kind of also true, right? So if I have something that is very soluble, agent 2 is relatively soluble in blood because see, it's partitioned itself into the blood. This one is insoluble, this one's relatively soluble. If I have something soluble in blood, that means it's going to go into blood very easily and it wants to kind of stay there. So think of that as it forming kind of like a sink or a store in the blood. And what that means is that usually the anesthetic induction and the recovery tend to be a little bit slower. And that makes sense because if we have something that wants to kind of form a sink or a store in blood, it's not going to preferentially partition itself back to that gaseous compartment on recovery. So a complex thing, but can be made very simple. So that's the reason why these agents work a little bit faster or a little bit slower than each other. So I want to talk about some physiologic parameters which might also influence the quality and speed of your anesthetic induction and recovery. So we know that in order for animals to become anesthetized, we've got to turn on the vaporizer. The gas and the vapor has to leave the vaporizer. It's going to go down the anesthetic circuit. The patient has to breathe it in. The patient develops an alveolar partial pressure of inhalant anesthetic. And there are arteries all around the lung. So the inhalant is going to go into the arterial blood. It's going to be carried to the tissues, including muscle, fat, and the brain, where it's going to cause anesthesia. And then on the other side of things, it's going to enter the venous circulation. It's going to be brought back to the lungs, and it's going to be eliminated. And this is kind of the flow chart of kind of how that works, right? So it comes from the vaporizer, goes down the circuit, comes in the patient, comes out the patient. So there's a very intimate relationship between the arterial blood supply and the alveolar partial pressure of inhalant anesthetic because you need to have blood flow to the lungs and a partial pressure of the inhalant anesthetic for it to be going into the body and taken to the tissues and cause anesthesia. And the flow of blood to the lungs can be very important when determining the speed of induction and the speed of anesthetic recovery. So let's say you have a big cardiac output. What I mean by that is your heart rate is high, your stroke volume is high, you are pumping out a lot of blood per minute. So let's say you're pumping out a lot of blood per minute. That means that the blood in both your arterial and your venous circulation is going to be traveling around the body pretty quickly. I'm going to compare two things, injectable anesthetics like propofol or ketamine versus inhalant anesthetics. If your cardiac output is big and I give you propofol, it's going to travel very quickly to the brain. Your anesthetic induction is going to be very quick. Now, if you have a big cardiac output and I just give you a mask of isoflurane, which is uncommon, but it happens. If I give you a mask of isoflurane, if the blood is going very, very quickly past the lungs, there is not going to be a lot of time for the inhalant anesthetic inside the lungs to equilibrate or transfer into the arterial blood. So if your animal has a big heart rate, a big cardiac output, and you give them a gas mask, the inhalant induction is going to be slower because we need more time for the blood to sit in the arteries when it's passing the lungs for that inhalant anesthetic to travel so it can get in there, get to the tissues, and cause anesthesia. Okay, the opposite side of that, low cardiac output. Let's say the heart rate's really low. The stroke volume is really low, maybe it's dehydrated, it's really sick, the heart rate's just low, it's vageling, whatever. If I give you a bolus of propofol, it's going to take a very long time for that injectable anesthetic to come up to the brain if your cardiac output is low. So your injectable anesthetic induction is going to be slower. That makes sense. This is why it's especially important in animals that have low heart rates or heart rates lower than you expect to give them injectable anesthetic and wait 30 to 60 seconds for that to hit the brain. Because by the time it hits the brain and by the time that injectable has gone from here to here, maybe you've given it more anesthetic in its veins and the animal will receive a relative overdose. So try some, wait, and then give more if you need to. Inhalant induction, when the cardiac output is low, it tends to be faster. And the reason why this is because let's say the animal breathes in isoflurane and oxygen. If the cardiac output is low and the flow in the arterial blood going past the lungs is really slow, there's going to be a lot of time for isoflurane and sevoflurane to sink into the blood as it's passing by. And then that means that when it's carried away from the lungs, that blood's going to be carrying a lot of inhalant anesthetic in it, inhalant anesthetic particles. And then you bring it up to the brain and it brings this big concentration of inhalant anesthetic particles and the animal falls asleep faster. So that's kind of how that works. So those are things you should probably be aware of when you're doing injectable or inhalational anesthetic inductions. And this was a chart I reviewed previously, but this is basically just where the inhalants need to travel in the body. So I would say basically the most important relationship we have here is the alveolar partial pressure of the inhalant anesthetic and the arterial, because that really favors induction. And on the converse, it goes from the arterial supply into the tissues like the brain. But think about it, it also goes into places like muscle and fat and other tissues. And this is why at the end of an anesthetic, it's really important to give animals enough time to wake up from that inhalant anesthetic, because it has to leave all the tissues. So yes, you want it to leave the brain, because if it leaves the brain, the animal is going to become conscious. It's going to open its eyes and it might start chewing or it might start swallowing, and you might think it's ready to be extubated. However, I'd encourage you to wait a little bit longer. And the reason why that is because animals, if they've been asleep for a long time, if they've been asleep for more than an hour, there is going to be a store of anesthetic in their tissues, their muscle and their fat. You need to give that anesthetic time to come out of the animal's body. So a very common thing is that if animals have been asleep for a while and they wake up very quickly, that they will scream, they will have nystagmus, and they will roll and they'll have emergence delirium. And the reason why this is because although we've had some anesthetic leave the brain, we still have anesthetic in the muscle and the fat, and the animal is still in the excitatory phase of anesthesia. It is still breathing off anesthetic, and usually if you sniff near those animals, they will smell a little bit like gas. So I'd encourage you, even if the patient looks ready right away, if they've been asleep more than an hour, give them 10 minutes for every hour they've been down to sleep. And if they try to wake up before then, give them a mg per kg of propofol and get the pulse ox back on them, and just give them another opportunity to wake up. And usually when you do that, they tend to have a better quality of recovery. So it's very much about this like waterfall-like relationship between the outside gets the lungs, it's transmitted around the body, but not just the brain, other tissues, and then it has to be eliminated. So I want to talk about a couple of things that will favor the development of an increased alveolar partial pressure, because this will usually speed the quality of your inhalant anesthetic induction. It will make your patient fall asleep a little bit faster. So we talked about how partial pressure is absolute. So we need to be able to develop a partial pressure, or basically enough molecules, enough of a presence of iso or sevoflurane in the lungs in order to cause anesthesia. So things that will favor this, these kind of make sense. Increased inspired concentration of your inhalant. That makes sense. The higher the vaporizer setting, the faster the fresh gas flow rate, the smaller the volume of the anesthetic circuit, the faster and the stronger that change in inhalant concentration is going to reach your patient. So that is why when we start an anesthesia, even if we plan to run the animal at 1 or 1.5% isoflurane the whole time, we usually wash in the circuit at 2, because that will favor a faster development of an increased alveolar partial pressure of anesthetic. Increased alveolar ventilation. This also makes sense. So something that I want you to know about the gases we give patients is that oxygen diffuses. So if a patient does not breathe, oxygen will still diffuse into the alveoli and into the arterial blood, okay? So if your patient is on 100% oxygen, even if they don't take a breath for a minute or two, they are not going to become hypoxemic from low fraction inspired oxygen, because that oxygen is going to diffuse, okay? But the inhalant anesthetic needs to be in open alveoli that are conducting gas exchange with the arterial blood. So the patient needs to take deep, regular breaths in order to develop a sufficient partial pressure of isoflurane. So this is why if patients don't breathe for like 2 or 3 minutes after inhalant induction, although you want to give them time for their CO2 to come back up so they breathe on their own, because CO2 is a very big stimulus for breathing, you also probably want to give them a breath after a minute or two, because what will happen is that as that propofol or that injectable wears off, if they haven't developed a sufficient alveolar partial pressure of anesthetic, they might wake up. So that's something to be aware about. And decreased removal from the alveoli. So again, this comes back to this, and it comes back to this. So removal, we're talking about the arterial blood supply. So if you have a patient whose cardiac output is low and the heart rate is low, the removal and the flow basically of blood going past the lung, where the inhalant is going to be really low. And that makes sense, because we know that with low cardiac output, there's going to be enough time for that inhalant anesthetic to kind of form a sink or develop a partial pressure in the blood, and the converse is true. So those are all things that increased partial pressure of isoflurane and increased partial pressure of inhalant anesthetic. That's how you can get that. So the last thing I want to talk about in this session about inhalant anesthetics is MAC. So MAC is something very important, and it relates to the doses we give for inhalant anesthetics, and there are also a couple of different definitions of MAC that you should probably be aware of, but just focus on the main one for now, and the other ones are helpful, but they're not absolutely necessary to everyday learning. So MAC is an abbreviation, MAC. So MAC is the minimum alveolar concentration of inhalant anesthetic that is needed to prevent response and movement to a supramaximal noxious stimulus in 50% of patients that are anesthetized. Okay, so what does this mean? Basically what this means is that if I have 100 dogs and I anesthetize them on isoflurane, if I poke them with a pen, a noxious stimulus is something that shouldn't be painful, it's just annoying. If I poke them or if I touch them at 1.3% inspired, 50% of those dogs are not going to move. That means the other 50% are. So MAC is a range, okay? And it's only for 50%. So basically what this means is that if you have a patient and we say the MAC of isoflurane is 1.3 to 1.6 in dogs, that means in a population of 100 dogs, if you anesthetize them on 1.3, half of them are going to wake up when you poke them and half of them won't. Now, this means that most of them fall in this range, but there are going to be some animals that maybe fall a little bit lower. They just need less to stay asleep. It's just individual animal variation. And there are going to be some animals that require way more. It is just a fact. So it represents a dose range. And the MAC of isoflurane in dogs and cats is 1.3 to 1.6. And the MAC of sevoflurane is 2.3 to 2.6. So that means if you just have a patient like sitting on a table, getting shaped for surgery, I would call that a noxious stimulus. 50% of them are not going to wake up on 1.3 to 1.6. So after the circuit's washed in, it would probably be acceptable if you're monitoring the anesthetic depth to turn the patient down to 1.3 to 1.6%. Now, I want to talk about a couple different of MAC definitions that are important to know, but they have been added over time. So the first one I want to talk about is MAC awake. So MAC awake is the minimum alveolar concentration of anesthetic that you give to animals where 50% of them will respond to a verbal command. So obviously when you talk to dogs, they're not going to say something back to you. But in people, MAC awake means if I speak to you, will you respond or will you open your eyes? And basically what this is it's just a fraction of the other MAC. So MAC awake is 0.3 of the other MAC. So the important difference between these two is that this one prevents the patient, 50% of patients, from moving at this concentration. And at this concentration, at MAC awake, it is 0.3 of this, so it's probably like 0.3, 0.4, 0.5% isoflurane. And that means that at 0.3, 0.5, 0.4% isoflurane, the patient will respond to a verbal command. So that means the dog might open its eyes, it might move, it might twitch, it might have spontaneous movement. But the important difference to know between these two is this one prevents movement, and this one is basically at the point that animals regain consciousness. So this means if you are running a patient somewhere between 1.3 and like 0.3, 0.4, 0.5, they will be unconscious, but they can still move. And this is very important to remember because if you are running patients on very low gas, like they're super sick, or you're using a balanced anesthetic technique where you're able to reduce your gas, you need to be vigilantly monitoring them because they can move, but they might not necessarily be conscious. And although moving can be frustrating, it can be really startling for maybe someone who didn't expect it. Maybe you knew that because you studied this lecture or you read about it, but maybe the surgeons don't know that, or like maybe the animal's really big and moving would be detrimental to the surgery. So that's something that you need to be aware about. MAC awake is lower than regular MAC, and they can be moving, but they will still be unconscious. So there you go. MAC BAR. So MAC BAR is around 2 times regular MAC. And MAC BAR is the minimum alveolar concentration of anesthetic that blunts an autonomic, or basically a sympathetic nervous system response to surgical stimulus. So we see that MAC BAR is 2 times this MAC. So this one, where the MAC of isoflurane is 1.3 to 1.6, that's just for me to get a dog on a table and poke it, and for it not to respond. But MAC BAR is the one that's going to blunt the sympathetic nervous system's response to surgical stimulus. Now, surgical stimulus is going to be painful. It is going to be a lot more sharp. So that is why this MAC is much higher. And all of these numbers, MAC, MAC awake, MAC BAR, these are calculated without any other anesthetic or analgesic drugs on board. So this means that if you just got a dog on a table and gave it only gas, no propofol, no opioids, no phenothiazines, no ketamine, no analgesics, no NSAIDs, you would need 1.3 to 1.6. Now, if you were doing surgery on this patient, in order to prevent the sympathetic nervous system from responding to surgical stimulus, you would need to have like around 2 to 2.5 times MAC. So basically what that means is that you would need to run your animal on like 2.6% isoflurane in order for them to not respond to surgery. And we talked about earlier how increasing doses of inhalant anesthetics, they can cause a decrease in heart contractility, they can cause vasodilation, and they cause hypotension. And they also form a store in the blood and in the tissues. So the more you give them, the more you tend to impair heart and vessel function, And the more you leave in the tissue, so not only should it take them longer to recover, you're also going to make the blood pressure a lot worse. And you're not providing things necessarily like analgesia, which although animals can't feel pain when they're asleep, they can still experience nociception, and that means their body is still encoding and like running all the hardware of all the same things that pain does. It's just that they're unconscious. So that's why it's really important, instead of just like using these really high gas settings, to use other techniques to help lower your inhalants, because together they can make a really nice technique, but on their own they don't provide a balanced anesthetic triad. So that is all I have to say about inhalant anesthetics for today. We will take some pictures of this board and we will post it to the online learning platform, and that's it.